Thank you, Deandra, for that kind introduction. So I will just go ahead and warn everyone that I was very enthusiastic about the opportunity to speak here today about research. And so I've realized that I probably have twice as many slides as it is possible for me to get through in 10 minutes. So I'm actually not going to get to the findings that we have from a pilot study that we conducted in 5 low and middle income countries. But I really encourage you, there are 2 posters out in the lobby there that you can look at throughout the day or during the reception that do explain more about the results. And I'm also happy, and as many of my colleagues would be as well, to talk about some of those findings. So I did just want to talk a little bit about understanding and addressing mental health disparities among sexual and gender minorities in the southern US as well as the global South. And I'd also like to say that my pronouns are she, her, hers. All right, so a little bit about what we do know. So sexual and gender minorities are disproportionately affected by stigma, discrimination, violence, and victimization. And this is true around the world. And, so there's plenty of research to support this. Largely the research that I've used to support these claims that I'm making are meta-analyses or systematic reviews. And so a systematic review found that among transgender individuals, 44% had experienced violence or victimization. So extremely high level of violence and victimization among transgender individuals. And also a meta-analysis of LGBT individuals found substantial experiences of victimization with rates higher than those of heterosexual individuals. And as you can see on the right, this is a little, just a little reminder of how severe this is. So this is actually from the Trans Remembrance from 2019, and it's the Trans Murder Monitoring Project. And based on the results of this study between 2008 and 2019, there have been over 3,000 transgender or gender diverse people murdered throughout the world. And I can tell you that this is extremely underestimated. These are reported deaths, reported murders. So this is real and harrowing information. So what I also want to say about the prevalence of discrimination, violence, and stigma is this very much aligns with the minority stress model, and that is very much related to mental health, and that it basically purports that the stress that sexual and gender minorities undergo due to stigma, discrimination, and violence, elevates their levels of stress. The levels of stress are often persistent, and it does increase the likelihood of poor mental health outcomes. All right. So there's also growing evidence of substantial mental health disparities among sexual and gender minorities. So comparing sexual and gender minorities to non-sexual and gender minorities, but also within sexual and gender minority identities. And so we're starting to uncover some of these intricacies in these relationships. So just a few facts. LGBT individuals have over 2 times the risk of lifetime suicide attempt, 1.5 times greater lifetime or past 12-month risk of depression, anxiety disorder, and 1.5 times higher risk of substance dependence compared to heterosexuals. Interestingly, we start to see a within group difference when we look at bisexual individuals who have greater rates of lifetime depression and anxiety than heterosexual individuals, but when compared to their lesbian and gay counterparts, they're equivalent or even worse. So we have a lot to uncover about these different identities, these different sexual and gender minority identities. And this, again, is not just true in the global South or in the southern US, but this is true across the board. And then finally, in a large US sample of young people, sexual or gender minority youth had a much higher rates of depressive and anxious distress compared to cisgender males and cisgender females. So plenty of evidence to support that there are disparities among sexual and gender minorities. So I wanted to next talk about the gaps and limitations and kind of in the research overall, but specifically as it relates to the Southern US and the Global South. So basically, little is known about the mental health of sexual and gender minorities in the Southern US or Global South, particularly outside of the context of HIV research. We have learned a lot about mental health and other health outcomes among sexual and gender minorities through HIV work. And as Deandra mentioned, I've spent a good bit of my career doing HIV work, so I'm quite familiar with some of that evidence. So it's been very important. A lot of the knowledge that we have gained about mental health in sexual and gender minorities has come from high-income countries. Most of the reviews and meta-analyses that I was citing before were primarily high-income countries, and often they included HIV studies as well. So the one kind of limitation of HIV studies is often people who are recruited for HIV studies who are sexual and gender minorities are recruited based on behavior. And so largely that includes men who have sex with men, transgender women who have sex with men, and increasingly transgender men who have sex with men. And so what that means is that there are many sexual and gender minorities who are excluded from that research. So in order for us to really understand the unique needs of all of these different sexual and gender minority identities, as well as their intervention preferences, we've really got to look across all of these identities, and that includes gender identity and or gender expression, and as well as sexual orientation, and conceptualizing sexual orientation in a broad way. So we also have limited information on the social determinants of mental health across sexual and gender minority identities, cultures, and contexts. So I'll talk a little bit more about that in a minute, but this is really important because we do know that these vary based on identities, based on cultures and contexts, and that is very important as we, in this program, are looking at sexual and gender minority individuals in the US South as well as the Global South. We really need to understand what factors are driving poor mental health outcomes. Intersectionality of identities has been underexplored. That's been mentioned already today, that the stress can really pile up when you're talking about sexual and gender minority identities, perhaps identities, racial and ethnic minority identities, social economic status, morality, which are all related to this work that we're pursuing. But that's something that we really have to do a better job of understanding. There's been little focus on mental well-being and resiliency in mental health work. I would say that in HIV work, that is beginning to gain a lot of momentum, but I think in work specifically focused on mental health alone, I haven't seen as much of that. It's incredibly important for us to understand what processes do help a person become resilient, and if those are things that we can then use as intervention tools. So also lack of rigorous longitudinal studies on mental health or on sexual and gender minority health. And the reason that really matters is, much of what we've relied on is cross-sectional studies. And if we really want to understand the factors, all of these factors, these social determinants that are influencing mental health outcomes and establish causality, we have to have longitudinal research. And I will just skip on and just say that there's an alarming scarcity of interventions that are culturally and contextually relevant to address mental health disparities, particularly in low resource areas. So how do we plan to move the field forward? I have like a minute, so I'm gonna roll through this. First is that we really want to refine the way we're thinking or characterizing sexual and gender minorities and mental health. And this is not completely novel. Many people have been thinking about this for a long time, but we do need to acknowledge that everyone has a gender identity and or a gender expression, and everybody has a sexual orientation. Those are two very separate constructs, but need to be measured simultaneously so that we can understand their impacts on mental health outcomes. Also kind of refining existing theoretical models. This model is very much related to the minority stress model that I mentioned, and also includes an adaptive version from the Commission on the Social Determinants of Health. But the primary things here are really considering the importance of these different cultural, political, and social contexts, particularly in the southern US and in the global south. So actually you can see this pretty well, nice. But we also need to look at this again, as I mentioned, by sexual and gender minority identity, by intersecting identities, to really understand mental health disparities and to guide appropriate interventions. So in order to address mental health disparities in these southern US, global south, we really need to engage local communities. We really do intend to make this a community-based participatory research approach. And also we want to address gaps by conducting longitudinal studies to identify those unique predictors, outcomes, treatment needs, et cetera, specifically by sexual and gender minority identities and contexts. And use those findings to develop brilliant interventions, and then share the information bidirectionally from the southern US and the global south, because we have a lot to learn, and potentially a lot to learn about developing interventions that could be effective in both contexts. So I will stop there. Thank you.